Witam serdecznie.
Ladies and gentlemen, welcome. This is a webinar entitled Gene Therapy in DMD Patients, Practitioner's View. My name is Adrian Jerzak and I am the president of a foundation, Together Against the DMD. And as regards housekeeping issues, I wrote you an email about it. You will receive this webinar both in Polish and in English. You can listen to it in Polish and in English. So it's enough to press a globe or 3 dots, then more, and select interpretation, and then Chinese for Polish, actually. And if you want to listen to the interpretation into English, choose English. I'll give you a moment to set it all up, and I will give the floor to Alicja Orlik, who's also representing the same foundation as I.
Dzień dobry Państwu.
Hello, ladies and gentlemen. A warm welcome to all participants of today's webinar. Truly happy to have so many people join us. We have parents of kids with DMD, but also doctors and journalists. This webinar was prepared especially thinking about parents and their questions and doubts and the need to understand the stage at which we are in treating DMD. And let me briefly tell you what's going to happen today. So first we will have a presentation by Dr. Arif Khan, who is going to talk about gene therapy in DMD. He's going to present his clinical experience from Dubai. Dr. Arif Khan is a pediatric neurology consultant with more than 16-year clinical experience. He's treating neuromuscular diseases. He's a specialist, a British board certified specialist, consultant pediatric neurologist. And after his presentation, we will have one more presentation by a mom of a son who has recently been treated with gene therapy, Madam Renata Karata, and then after her we will have a Q&A session. So thank you very much for all the questions that you've sent us. And Dr. Arif Khan will comment on these questions one by one after each question. We will ask him for a short answer, and we also know that not all of the questions will be answered right away. We won't have enough time to do that, so possibly we will address just some of the issues in materials that we will send you later on. We'll see how we are doing on time and whether you will need more details. So I give the floor to Dr. Arif Khan. And if you could introduce.
Thank you, Alicia. Thank you, everybody. My name is Dr. Arif Khan, as the other panelist rightly noted. I'm a consultant pediatric neurologist working in Dubai. My training is from the UK, and I came to Dubai about 10 years ago. So I am at a hospital here called Fakir University Hospital. I also have founded neuroscience centers in Dubai for children with various neurological issues. I have a few channels that I run on YouTube to help people understand neurological conditions and neurobehavioral conditions. If you're interested, I can share that later with you. And today I've been given this task to talk to you about what Duchenne muscular dystrophy is, which way is it going, what are the therapeutic modalities available, and what our experience here in Dubai is of treating children with Duchenne muscular dystrophy. So can I share my presentation now, if you allow me? It's visible, Alicia? Okay. So I probably will take 15 minutes, maybe a few minutes here and there. So I would just start off with this definition of Duchenne muscular dystrophy. So Duchenne muscular dystrophy, or DMD, that's how I'm going to refer it to, is an X-linked genetic disorder that leads to progressive muscle degeneration and weakness. It affects boys, as we know it, with symptoms often appearing in early childhood. So normally you won't see this in a 1 or 2 year old child. Although they already have the disease, you don't see symptoms in them usually. In some you do, but mostly you don't. By the time a child reaches 3, 4, or 5, they get picked up for a diagnosis in 3 ways. Either they present with weakness, they cannot climb stairs, so they get picked up by the doctor, or they do regular blood test, their liver functions is raised, like ALT and AST, that's how they get picked up. Or the third way is that their CK is raised, and they were doing CK for something else, and CK comes raised, and then they do the genetic test to confirm. So these are 3 ways. And the one more fourth way is where someone have already someone in the family with Duchenne, and that's why they test their children. And it happens because of a mutation or an error in a gene called dystrophin gene. And you have to remember that dystrophin gene is the largest gene in our body. As you know, we have close to 22,000 genes. And dystrophin gene is the gene that is responsible for Duchenne muscular dystrophy. And any child that has mutation in dystrophin gene, dystrophin protein is not produced, and therefore the muscle cell stability is lost. So in all our body, the muscle breaks down and the new ones are regenerated. In a child with Duchenne muscular dystrophy, the muscle breaks down rather quickly and the regeneration process is very slow. So therefore, their muscle dies down or becomes fibrosed and turns into fat or fatty tissue very quickly. And that is what Duchenne muscular dystrophy is. Now, we have talked about the genetics. How common it is? It's about 1 in 5,000 children. In places where it is more common, like in the Middle Eastern region, it's more common. In some parts of Europe, it's more common, but usually 1 in 5,000. And the clinical progression happens like this. They're diagnosed when they are 3, 4, or 5. Their best strength is at 6 years of age, 6, sometimes 7. And from 6 to 7, the functional decline starts when they start losing their strength. And by 10 to 12 years of age, most of the children, if not treated, they lose their mobility and they are wheelchair bound after that. And usually, before all these treatments came in, their lifespan usually was mid-20s to up to 30s, depending upon the kind of care they receive. I've just reduced the volume here. I've just done a collection of videos here. So this is a 3-year-old boy. As you can see, he's trying to turn and he struggles. So this is not picked up by parents usually, and they ignore it. But you can see he climbs onto his knees even, partial Gower sign. Now, this is a slightly about 3.5-year-old boy who's trying to walk upstairs. And you can see he's holding on to the rail and walking. But again, parents feel, okay, he might catch up, so let's wait and see. But this child already has some symptoms in the beginning, and when he starts climbing stairs, it becomes more obvious. Now, as the disease progresses, at 6 years of age, this child, you can see him walking. He's developed mild lordosis. His back is curved, and you can see mild weakness of his pelvis. He's walking like what we call as a duck walk or waddling gait. It is not full, but it's partial. Again, many a times they are not picked up at this age. At 7 years, if you compare 2 kids of the same age, now the one on your right, Chris, is 7 years old, and on the left is another child. You can easily see who has Duchenne's muscular dystrophy. This boy is trying to run, but he's almost fast walking. And from 7 or 8, that's when the weakness gets really at its peak and life starts getting difficult. So very poor neck strength and core strength. He's not able to sit up anymore. Even when he tries to get up from chair, you can see he straightens up and it takes time. Now he's trying to walk, swinging his arms to propel himself forward. And you can see the duck gait or waddling gait has become more prominent. He has to turn around to sit up. And you can watch him sitting up and standing now. It takes at least 10, 15 to 20 seconds. This is called TTR, or time to rise. You can see that. This is one of the markers we use to see how the treatment is working and how the disease is progressing. By the ninth year, the strength continues to fade. You can see it's getting more and more obvious. His lordosis has become more prominent. He's tiptoe walking, you can see that. And he's swinging his pelvic girdle, almost typical of waddling gait. Look at him tiptoe walking there. But he's still mobile at 9 years. A child grows older and they're trying to lift one leg up and show how the pelvis falls. Not a sign that you need to remember. He's able to lift his arm above his head, so all good there. At about 10 years, in many kids, walking is not possible. So they get onto a wheelchair. And from here on, the weakness of the upper body sets in. That's when you start focusing on the function of the upper limbs, the swallowing, the respiratory symptoms, and all that. Look at this boy. He's trying to raise his arms up. He's about 11, and he can't. This is the maximum he can do. He cannot raise his shoulders above the shoulder level. But he still can eat. He can feed himself because he can flex his elbow. Now, with time, because he's sitting all the time and his core weakness establishes, about 90% of boys will develop scoliosis. And not all of them need surgery, but many of them will require surgery to help their lungs sustain their breathing. You can see this boy having a slight curvature of the back. At 14 years, it's very difficult for them to bring their hand to their mouth. You can see in this boy, he's struggling to bring that hand to mouth. And he's having a back neck support because he gets tired very much. He's slowly going to lose his neck control even, and he will need support on either side of his neck as well. Now, this is a 14-year-old. As the child grows older, things move away from motor to more respiratory and cardiac issues. So the child starts needing cough assist to help them clear their secretions. So you will see this machine in lots of kids who are 15, 16, and 17. Cough assist machines to help them clear their secretions. As they grow older, BiPAP machines are required to make sure their oxygenation and breathing continues at night. So some start only at night, as you can see there, and then some of them need during the daytime as well. And eventually, many of them, because of a bad pneumonia or chest infection, they get admitted to ICU, and unfortunately, many just pass away. But because I've been doing this for now nearly 25 years, 16 years out of which I've been a consultant managing neuromuscular conditions, I've seen a lot of stories go through this. So all of them have their own trajectory, but this is like an average of everything. Now, so you will always hear a terminology called NSAA, which is the North Star Ambulatory Assessment, which is a gold standard we use for measuring strength. So if you see the NSAA on the vertical axis here, it's scored as 0, 5, 10, 15, and so forth. And on the x-axis, you have the years, 4, 6, 8, 10. Now, the best time of a child with Duchenne muscular dystrophy when the strength is at its peak is 6 years. It can be plus or minus 1 year, but average is 6 years. So he's at its best here. After this, the weakness sets in. And if you take an average, a child at 6 years has a score of about 25 or 26. And within 6 years, he gets down to about 10 or 11. So they lose about 15 points in those 6 years. Okay, just remember this as we go along. Now, yes, Duchenne muscular dystrophy is a muscle problem, and there is loss of muscle mass, weakness, difficulty in running, jumping, walking upstairs, and all that. But they also have problems with sometimes cognition, learning. Many of them have problems with speech, and they're delayed speaking. Short-term memory is affected in many. They have difficulties at school. Not all, but many of them. But sometimes that gets missed. Many of them, or almost all of them, eventually have bone problems. They develop scoliosis, lordosis, as I told, and fractures, because if they are not mobile and they're on steroids, their bone becomes more and more fragile. Of course, they have problems with lungs later on, and of course, heart, because heart is a muscle, so that it becomes weak, and it can lead to cardiomyopathy, and therefore it has to be observed, or surveillance has to take place every year once they're beyond 10 or 11 years of age. Now, who are the people involved in our team? So, of course, there is a pediatric neurologist here. Can you see my cursor, Lisha? You can see my cursor moving? Okay, thank you. So you need a pediatric neurologist to oversee the care. Sometimes this role is done by developmental pediatricians in some countries like UK. You need a pulmonologist for managing the lung complications. You need an endocrinologist or a hormone doctor to look at growth and development. You need a physiotherapist, one of the most important professional in a child with DMD. You need an orthopedist, an orthopedic doctor to manage your scoliosis, your hip issues, tiptoe walking, and all that. And what many people forget is psychologists and mental health professionals. Because as kids grow older, they understand their condition. And that's when they need support, not just from family and friends and relatives, but also from professionals. And they, of course, need a cardiologist, especially as they grow older. And in the middle, there is the child and the family. Of course, I don't have to say anything about that. Many a times we include nutritionists or gastroenterologists to help monitor their nutrition. Now, let's go on to treatments. So I've just put this image here to show you that what are the areas of treatment we are talking about. So I have divided it into upstream therapies where you have things by which you can increase the dystrophin. So your exon skipping, your gene therapy comes in that. And there are treatments that are called downstream therapies, which are here. Now, these are things that reduce the impact of the disease. For example, protecting the muscle, inflammation and fibrosis. To reduce the swelling and the fibrosis in the muscle, there are medications. Steroid is one of them, but many are coming along. Some have already come. I will talk to you about that. Then there are mitochondria. Mitochondria is the powerhouse of every cell. There are medications for that on their way. Then monoclonal antibodies, antibodies that are produced externally and then given to children, is again, research is going on in that. Thromboxane receptor antagonist for cardiac, yes, on the way as well. A lot of research going on the heart side to protect the heart. And cell-based, like stem cell therapies and all that is coming along. So I won't have time to go into all of them, but I'll tell you what we're using. So in the GCC region, we were the first ones to use Juvenostat. As you know, it's a medication that was approved by FDA in 2024. And it reduces inflammation and loss of muscle. And this has been approved about 18 months ago. And the first child we treated was about 2 months back. And the decline is significantly smaller in a child when you start Duvisat. Now, there are no comparison studies between this and gene therapy, but this is more on the peripheral side, which is the downstream treatments. Whereas when we talk about gene therapy later, it's the upstream therapy. So Duvisat is one that we use. Vamorolone is again the downstream side. It's like a steroid, but it's a steroid that's designed specifically for DMD patients, targeting muscle inflammation and promoting strength. The good thing about this particular steroid is that the focus is on minimizing side effects. So the side effects of poor bone health, short stature, infections in kids, all that is reduced once vamorolone is given. Again, it's expensive, but it has a better effect overall. Now, coming to the upstream treatments, where we talk about gene therapy and exon skipping. I'm sure many of you would have heard of casimersen, eteplirsen, golodirsen, or also called as Amondys, Exondys, and all those. So these are called exon skipping treatments, which started coming in 2016, about 9 years ago. And most of you know what it is, but for those of you who don't, I'll just explain that. So as I said, the Duchenne gene, the dystrophin gene, is quite large. It has 79 parts or exons. Now imagine I'm looking at a short part, 49 to 52, yeah? So if this child has a deletion of one exon, 50, imagine this is not there. So the 49 will not fit into 51 because see, this arrow is here, this arrow is here. So they don't fit into each other. Now, what exon therapy does, exon skipping therapy does, it removes this 51. So it skips exon 51 so that now 49 can fit into 51. This arrow will fit into this arrow. So that's called exon skipping. Now, there are exon skipping for 45, exon skipping 51, exon skipping 53. And many are on the way. But at this point of time, about 30% or 25 to 30% of Duchenne muscular dystrophies are amenable to this treatment. That means you can use this treatment. In the 70%, till now, it's not available. Now, coming on to the specific gene therapy, which is called delandistrogene moxeparvovich. It's a very long name. I'm not able to pronounce it correctly, but I did. So what is it? So what they do is they take a virus, and for Duchenne muscular dystrophy, they use a virus called AVRH74. Now, as you know, virus has a very strong property of reaching out to different cells in the body. So they take the virus, they put in the gene inside, they remove everything from the virus, the bad part. They put in the gene, but the shorter form of the gene, or microdystrophin as it's called. And they also put something called as a promoter, something that makes that particular complex go to all the muscle cells. And that is sent inside the body by IV infusion. So you can see here, this is the virus, that is the gene, and it's put inside the cell. It goes through the cell, reaches the nucleus of the cell. You know, we have billions and billions of cells, and they have a nucleus. And once it reaches the nucleus, the gene is released, and the gene sits in the nucleus, and it releases dystrophin. Now, many people ask me, oh, what if my child gets this, of course, this gene? Will he pass it on to his kids? That's not possible, because this gene doesn't go and connect to the DNA, the original DNA of a child. It sits outside and it releases the dystrophin. So the boy will not pass it on to his kids in the future. Then what do we do with this? So if the child is eligible, so we look at, there are a number of factors for eligibility, including the type of mutation, whether he has any liver issues, then we cannot use it, whether any previous treatments have been given. So there are many assessment factors. And we also check their antibodies, so for that virus that we're going to send in. If a child has antibodies, then they're not eligible to receive the gene therapy. We cannot do anything about that. But if they're negative, then they are ready for gene therapy. So we call them in. They come in for a 3 months program. The first month is about assessments with a gastroenterologist, respiratory doctor. We get them checked through a swallowing specialist, a physiotherapist, a cardiologist. A complete assessment happens. While we wait for the genetic test results to come back, we repeat it. And when the medication is ordered, it takes about 10 days to come. So overall, you can say 20 to 30 days for preparation. Then the infusion is given. For that, the child is admitted for 3 days in the hospital. We call it day 0, day 1, and day 2, which helps the child stabilize even after the infusion and then can go back to their house. But the infusion itself takes about maybe 1 hour to 2 hours, depending upon the size of the child. For older kids, it takes a little longer. And after that, after the gene therapy has been given, for 2 to 3 months, we do regular blood tests to see the reaction, for example, for liver functions, for platelets, and so forth. And this supervision is very strictly followed. Even after the child goes back to their home country, they keep sending us blood results. At least for 2 or 3 months after the gene therapy is given, we follow them up from the blood test perspective. Once the liver functions are all fine, then we discharge them. We don't ask them to do blood tests regularly. We reduce it slowly over time. So there is a protocol, and all kids follow this. So then, what does the gene therapy do? What can we expect? I know you will have many questions related to this, but I'll just give you what we know at this point of time. So you can see the same graph here. This is the North Star ambulatory rating. I remember I told you about 22, 23 is a score at 4 years of age. And this is age. 0 meaning when the gene therapy was given. And this is like 4 to 5 years of follow-up, as you can see here. So imagine a child in the red who has not received gene therapy, and his score at 4 years of age is 22 or 23. After 4 years, he will drop, or 4.5 years, he will drop down to about 18. You can see here. Their NSAA score will drop down to 18. Whereas a child who's received gene therapy, the NSAA score will be from 22, will be about 26 or 27. So what they're saying is the difference between a child who's not received and has received is about 9 to 10 points. And 9 to 10 points is the difference between a child who's able to walk at 10 and a child who's not able to walk at 10. Now, there were some secondary endpoints also, which is like time to rise, also 10-meter walking and all that, which have significant benefits. But NSAA itself showed benefit definitely in number, but statistically it didn't show. We'll talk about that later, why some people use that as not a form of approval that they can give to go ahead with it. Now, so that is gene therapy and the non-gene therapy treatments available for Duchenne muscular dystrophy. That was my short presentation, and I will let Alicia take over from here.
Thank you very much, Doctor. Thank you for the presentation, which described to us the current state of the art in medicine and potential therapies which can be considered in children with DMD. Now, I would like to introduce to you Renata Kalata. Renata is a parent of son Tymoteusz, who has just been administered with gene therapy. Let me just first check technically if Renata is ready. Yes, she is. And on our part, we would like to say that it's very important what she's going to say, because many people ask themselves questions. How is Tymek doing after that infusion? So we hope that Renata will tell us more about any potential adverse events of the gene therapy in her son, and tell us if you have seen any changes since the therapy was administered. We realize it's very early, but still, it would be great to hear personally from you as the mom of a child who has just been administered with that treatment, and she had been fighting for long years for making her son eligible. So tell us more about Tymek now. Hello, everyone. I hope you can hear me well.
Halo, halo.
Just confirm if you can hear me.
Bo ja lubię mówić.
But just to be on the safe side, I will start talking. So, indeed, Tymek is one of the lucky boys that were qualified for that gene therapy. Initially, we opted for Boston. We didn't know what would happen in Dubai, and there were many question marks along the way. Yet, Tymek decided he wanted to do it in Dubai because he loved the sun. And I'm a pragmatic person, and since the costs were much lower than those offered by Boston, we opted for the Dubai hospital. So here I'd like to really express my gratitude to Dr. Arif, who saw Tymek in the beginning. He saw that my son was very weak. So we did the crowdfunding, then we took the flight to Dubai, and the walking test was impossible, but doctor still didn't exclude us. He said, let's give him some time, and I will always remain grateful to you, doctor, for that you gave us a chance. Now, briefly, to all of the parents who maybe have a dilemma, let me say about the standard of care that it's top-notch. You will be taken care of by a host of personnel, starting from collecting us from the airport, then assisting us to the hotel. We now have them on WhatsApp, so whatever is happening, they will quickly react and respond. And by the way, it's not only about Tymek, but also the whole family. We received help when someone was ill immediately. That mattered a great deal to us. Apart from that, rehabilitation twice a week was offered to my son. At the hotel, there is a swimming pool with warm water, so rehabilitation was possible also there by ourselves. Moreover, transportation is offered to the hospital and then back, which is a huge relief to both the parent and the child. The hotel is located close to the subway if someone wanted to do some sightseeing. Well, if you are here for 3 months, it's a good option not only to focus on treatment, but also to do some sightseeing and see a very different world here. Now, when it comes to the therapy, it went smoothly. Blood pressure was reduced a little bit at night, but it was then upregulated. Next week, his blood will be tested again. Oh, and by the way, as part of the care offered by the hospital, he is administered with the drugs that we don't have to pay for additionally. This is all included in the bill. Whether the therapy is working, I don't know. But my son is so determined, is so motivated, and I can see a huge change because he now smiles again. He regained some of his confidence, and he's really motivated to practice. He keeps nagging us to go to the hospital, and he really is very diligent. I don't have to press him. Also, he says he feels he is more powerful. What also moved me is that when Tymek was sitting on a sofa, he was able to go to the floor, and with one hand he was able to put on his shoes on his own. And I was just so moved when I saw that, because I haven't seen Tymek so self-reliant for a long time. Also, he's very proud of himself. He wants to brag about his walking. And at some point, as I said in the beginning, it was problematic for him to walk on the distance of 10 meters. And now he can go through the whole ward on his own, which makes him so proud. And I always liked to laugh that he is a bit like a camel looking at his back. But now the scapulas, I think, are more even. And it's like his back is now less protruded. Obviously, it's subjective. It's my own subjective opinion. But when I'm not a doctor myself. I'm just saying what I've noticed and what Tymek noticed. That is, when he lies down, his chest, which used to be very uplifted, is now more flat. He has noticed that himself and told me. Also, during rehabilitation, we see some contour of his thigh muscles, and it was not seen before. And previously, when we had to go to the restroom, I had to raise his right arm a little bit so that he can switch on the light, and now he can do it on his own. Also, he will put his 2 feet more narrowly. He's better coordinated. He can now turn around when seated if someone is behind him. I'm wondering what else I should tell you. I asked Tymek actually yesterday. So, how would you rate yourself compared to when he came here and he felt so bad he couldn't walk? And how much would he score? And he said that now he scores as much as 5, and it was very much lower. So he feels strong, and I can see how proud he is of himself and how happy he is. We will always remain grateful for the chance that Tymek has received. I hope that by observing Tymek, I will keep noticing more and more positive changes that I will happily share with you if you want to. And if you have any questions to me by other parents, feel free to contact me, send me a private message. I will be happy to give you any tips based on my experience. Thank you very much.
Dziękujemy bardzo za podzielenie
Thank you,
się
Renata, for sharing with
swoimi spostrzeżeniami. Ja wiem, że to dużo
what your
kosztuje,
observations are. I'm sure that
że
it
też
costs you
macie
a
za
lot.
sobą
And I'm
ciężki
sure
okres,
that you've gone through some
ale
very
cieszymy
difficult
się, że
moments.
widzimy, że widać
Still,
u
we are
Tymka
very happy to
przynajmniej
see
poprawę
and to
samopoczucia.
hear that Tymek
Jeszcze chciałam zapytać,
feels
czy
better,
jakiekolwiek skutki uboczne
at least
zauważyliście?
by his
Coś,
own
czego się
report. And by the
wystraszyło?
way, have you observed any adverse events, any side effects that maybe scared you? On day one after the gene infusion, when we arrived at the hotel, and by the way, you need to know that I like to panic a lot in my life. It seemed to me that he was very swollen, so I informed our contact persons, and I'm so grateful to doctor for that, because they never ignored any information from me. They came to us immediately, even though it might have been quite late after work. They came to us, they took us to the hospital, to the emergency ward, they tested him, and they said that he is a bit swollen, but just a little bit, and nothing wrong was going on. And indeed, on day 2, everything evened out, and we had no more such issues. So in fact, we haven't noticed any such events, and his blood tests every week were very positive. We have to wake up at 4 in the morning today because we are coming back home, because the blood results are so good. Wow, this is just so great.
Dziękujemy za zabranie
Thank you
głosu.
very much once again for your intervention, Renata.
Uważamy, że właśnie głos oczywiście matki jest tutaj
We think that
też
such a
istotny,
voice of a mother is also very important.
Wytłumaczyć
It's also important just to explain that it's not just a matter of how you administer the drug, what drug you're administering, but it's also hope. So we keep our fingers crossed for Tymek. Let's hope he gets better. And now let's move on to an Q&A session. These are the questions sent to us by parents, parents of kids in different ages. Some patients are already adult. So thank you very much for all your questions. And I'd like to move on to question number 1 to be asked by Adrian. Yes. First question, is deletion of exon 17 a definite exclusion criterion, or are there any possible exceptions?
Yeah, I'm sure you can hear me now. Yeah, so good question. The only exclusion from genetic perspective is if anybody has deletion of exon 7 and or 8 or 9, sorry. And the thing is, this deletion of 17, the reason this is noted somewhere in some literature is because these deletions were not in the initial research phase. They couldn't get enough patients for this, so it hasn't been tested. But any child with deletion 17, 18, 19, it's not an exception. We can go ahead with gene therapy. But we have to be more cautious in terms of the regularity with which we do liver function test. Also, if a child has very high liver function test or previous hepatitis or any other side effects already on top of their Duchenne muscular dystrophy, then we have to be more vigilant or we have to look for other options. But otherwise, just having exon 17 deletion is not a exclusion criteria.
Kolejne pytanie.
Okay, the next question. I understand that the deletion of exons 8 and 9 excludes a patient from treatment. However, is there any clear guidance regarding duplications?
No, because in duplication, obviously you have the exons. So whereas in deletion, you don't have the exons, or the exons are non-functional. So duplication is not a contraindication or exclusion criteria, but deletion of 8 or 9 or anything that includes 8 or 9, even if it's a bigger deletion, is a contraindication.
Dziękuję.
Thank you.
Dzień dobry, witam wszystkich serdecznie.
Hello
Nazywam się
everyone,
Kazirot
my
Adam.
name is Kazirot
Kolejne z
Adam,
pytań.
and the next question is, does
jako
vamorolone,
zamiennik
used
steroidów
as a
zamiast
steroid
deflazakortu
replacement
wpływa
instead
lub
of
koliduje
deflazacort,
z podaniem
interfere
albo
with
skutecznością
or
terapii
affect the
genowej
administration of
Elevidys?
effectiveness of Elevidys gene therapy?
Yeah, I got a message for unmute. Okay. No, it doesn't. Just like any other steroid, when we use, whether it's prednisolone or deflazacort, it doesn't interfere with Elevidys gene therapy. Similarly, vamorolone doesn't have any contraindications either way. So it can be used, not a problem at all.
Next question is the combination of gene therapy with another biological drug, e.g. Givinostat or the satellos molecule recommended? If so, why?
Okay, so we do combination therapies. Now, for example, we've had at least 2 kids whom we've given gene therapy. And after the gene therapy, they opted to go ahead with Givinostat. And we normally leave some time after gene therapy, sometimes up to 3 months before we start Givinostat. And we start the Givinostat. We monitor Givinostat for a few weeks. The monitoring period for Givinostat is not that long, but parents have to take it on a regular basis continuously. So there is no contraindication of combination therapies. And with the satellos molecule, we don't know because we haven't started treating it and nobody has at the moment. When it comes into the market, when there is some experience of that, we'll get better idea.
Następne pytanie, czy
Next question, is it possible to combine gene therapy with other treatments such as exon skipping?
Again, very good question. It is not regular. It's not about combining it. I'll just explain. I'll take a little time to explain both. So there are many kids who've had exon skipping previously because gene therapy was not available. And when gene therapy became available, they came for gene therapy after exon skipping. That's absolutely fine. So someone who's received exon skipping can go ahead and take gene therapy. Now, when a child receives gene therapy, there's no point going ahead with exon skipping because of 2 reasons. One, exon skipping is not replacing the gene. As I said, it's altering the reading frame. And whereas gene therapy is a more definitive treatment, with exon skipping, you have anywhere between 5 to 10% of dystrophin, microdystrophin produced, whereas with gene therapy, up to 40 to 50%. So it's a stronger therapy as such. So if you are already received gene therapy, there's no point going ahead with exon skipping. But in some kids who early on in 2016, 17, 18 have received exon skipping and want to go ahead with gene therapy, it can be given. Yeah.
Czy po podaniu terapii genowej każdy
After
pacjent
gene
będzie
therapy, will
wymagał
every patient need
długoterminowego lub
long-term or
dożywotniego
lifelong
leczenia
supportive
wspomagającego?
medication?
I
And
czy
does
zależy
this
to od
depend
rodzaju
on the type of
dystrofii mięśniowej?
muscular dystrophy?
So when we talk about Duchenne muscular dystrophy and gene therapy is given, many parents ask us, should we continue the steroids? We have to continue the steroids. We cannot stop the steroids there and then. Because our current understanding of gene therapy is 4 or 5 years of research plus 2 years of use after research, so about 7 years or 6 years. So we don't know till when the steroids will be continued, but at least for that period of time, we always tell the patient, continue the steroids you were on initially. With regards to other long-term treatments like Givinostat, once you start it, it's advisable to just keep continuing it because this medication has to be given on a daily basis to make sure the benefit continues. Same thing with vamorolone, the new steroids as well.
If a child has a chronic condition such as diabetes or another long-term illness, would this be considered a counterindication for gene therapy?
No. So thankfully, like adults have the type 2 diabetes a lot. In kids with, even if they have type 1 diabetes, not a contraindication. We obviously check their liver, we check their general health when we examine them before gene therapy is instituted. But if they have diabetes, we would not say, okay, you can't take gene therapy. No, we look at the other parameters, but with just the fact that they have diabetes, it's not a contraindication.
Następne pytanie, czy
Next
uszkodzenie
question, does
wczesnych
damage
aksonów, takich
to
jak
early
aksony
exons such as
2 do
exons
16
2 to
zwiększa
16
ryzyko
increase the
zapalenia
risk
mięśni
of
lub uszkodzenia innych narządów
myositis
podczas
or
terapii
injury or other
elewidyjskiej?
organs
Czy
during
stanowi to
Elevidys
przeciwwskazanie
therapy,
do
and
leczenia?
does this exclude patient from treatment?
So definitely exon 8 and 9, if they are deleted, because in the study, there were side effects more with these two deletions, 8 and 9. So if a child has 8 or 9 deletion, exclusively or in addition to a larger segment, then gene therapy cannot be given because they are excluded from that. But if a child has, say, exon 2, 3, and 4 deleted, then that is not a contraindication, or you can still go ahead with the gene therapy. And if a child has, say, exon 17 deletion or 18 deletion, then you have to be cautious a little bit, but still gene therapy can be given. But remember, it's 8 or 9 deletion only that you have to exclude kids completely.
Jeśli po terapii genowej
If
dochodzi do wzrostu
ALT and
parametrów
AST
ALAT
levels
i
rise
a
after gene
następnie ich
therapy and then
spadku, czy jest to
decrease,
uznawane
is
za
this
objaw
considered a
pozytywny
positive sign?
i czy ma to
And does
znaczenie
it have
dla
any
degeneracji
implication
mięśni?
for muscle degeneration?
Yeah, so LFTs invariably in most of the kids, they do have a pattern. They do increase and then they come down. Sometimes they need a little bit more help. Like we have to increase the steroids, or we have to give some other form of medication to bring it back. But they don't have any prognosticating factor. We cannot use it like a prognosis to tell us whether the child has responded to gene therapy or not. I've had kids who've had gene therapy and their liver functions were completely normal throughout. Whereas I have also kids who've had gene therapy in whom the liver functions rose very high, where we had to escalate steroid treatment. That doesn't decide whether the treatment is working or not. That tells us how much of immunological impact the liver has had, because you're giving a large load of virus to the body, which carries the gene. And sometimes the liver starts reacting to it. And when the liver starts reacting excessively to that virus, then the liver enzymes go up, which need interventions. So I won't use that to say, okay, whether the treatment is working or not. No.
Does gene therapy need to be repeated?
No. So gene therapy, if given once, it need not be repeated. We don't know how long the gene stays in the body, how long it's going to work. What we know is, as I said, for last 7 years, and it's still it's functional. The gene is functional, but does it have to be repeated? No. And moreover, if you use one virus, like an AAVRH in this case, you cannot give the same gene therapy again because you cannot expose the body to the virus twice. Otherwise, the immunological reaction will be very high. But some people ask me, what if there is another drug that comes in later where it's a different virus? Can we give it? Theoretically, yes, because it's a different virus, there won't be an immunological. But would you see any benefit from it, giving a second lot of gene therapy? It's very unlikely that'll be the case. So the advice is, and the current thing is that gene therapy need not be repeated.
Kolejne pytanie już
Next
pokrywa
question.
się z poprzednią
Overlapping with the
odpowiedzią,
previous answer that
i
you've given. I can't hear her.
w porównaniu z terapiami
The effectiveness of gene therapies versus exon skipping therapies. Which approach is considered more effective? And let me just add that the parents, we keep wondering about the efficacy, because in the United States, a lot of therapies have been approved only conditionally. So, is it harder to prove efficacy?
So it depends on what parameter you use. So exon skipping obviously came much before, in 2016, 17 it started. whereas gene therapy came very recently. Now, when you look at a parameter like dystrophin, how much dystrophin a child produces, microdystrophin, with exon skipping, we are looking at 5 to 10% of dystrophin that's produced. Whereas with gene therapy, it reaches 40 to 50%. So in that way, gene therapy is more effective. There is no doubt about it. But people talk about the impact of gene therapy. When we talk about NSAA scores or time to rise, the strength, basically, what changes it makes. There is no drug-to-drug comparison till now. And there is no way to definitely answer that question. But what we understand, now I'll come to the point where we talk about what is the outcome from this gene therapy that we give. See, gene therapy will not lead to a child, they're not claiming that new milestones will come. And the earlier you give the gene therapy, where most of the muscles are intact, the better the outcome is. So if you delay to 15 years, the child is still walking, and you delay to 15 years and 16 years, then most of the muscles would have already been degenerated. So you have very little to work with. So you will not expect that the child will start going uphill in terms of achieving new milestone. No. The aim of giving the gene therapy is to sustain or maintain the strength or reduce the velocity by which the degeneration happens. So on gene therapy, the child might still lose milestones, but it will not be as fast as the child would have lost those milestones if the gene therapy was not given. And that is clearly visible. And this is where the difference between how EMA, the European Medical Association, as well as an FDA, how they approach this. Because after the first year of the study, when the results came out, when they looked at 52 weeks, the 1 year of outcome, the main outcome, which was the NSAA, showed benefit, but it did not show statistically significant benefit. So FDA said, yes, we accept that the main point, the NSAA, was not significant as much, but the secondary outcomes, like the time to rise as well as the 10-meter walking, those were beneficial. So they said, we can see that happen in 1 year, so let's give an expedited approval. And after that, after 1 year, it got extended from just 4 to 5 years to beyond 5 years kids as well. What the European EMA decided was, because there was no statistical significance with the primary endpoint, therefore they said, no, we cannot approve it at this point of time. So this is, the outcomes are the same, but how you interpret that and how you use it to your own population, that's different as such. And clearly, now the second year's outcome has come. I think they have just released that this year, the year 2 outcome from the Embark study. And they are saying, I mean, it's not official and out now, but we will see that the gap between a child who's received and not received is increasing with time. So the second year, third year, you might see this difference becoming more and more prominent. But I'm still waiting for the official results to be announced. But I'm just giving you an idea moving forward. I hope I've answered that question as in the best way I could.
Tak, dziękuję bardzo.
Yes, thank you.
Ja bardzo dziękuję panu doktorowi,
Thank you
bo już
very much,
częściowo odpowiedział
doctor,
pan na
because you
kolejne
partly
pytanie.
answered the next question.
Jak pan myśli, jaki
What do you
jest powód,
think? What
dlaczego
is the
Elevidys nie został
reason
dopuszczony w
Elevidys
Europie?
has not
Także
been
już
approved in
pan
Europe?
doktor
So
odpowiedział na to
you've already
pytanie.
answered that question.
Kolejne pytanie jest takie dosyć
And the next
dwuczłonowe i
question
chcielibyśmy się też
is
dowiedzieć, na jakiej
composed
podstawie
of two
prawnej
parts, and we
terapia
wanted to
genowa
find
jest
out
aktualnie
on what
podawana na
legal or
terenie Dubaju.
regulatory basis is the therapy administered in Dubai.
Yeah. So the unique thing about Dubai is that because Dubai has its own guidelines and everything, but they sometimes use FDA and sometimes they fall back on EMA for their guidelines. So for example, when we talk about spinal muscular atrophy, we use both FDA and EMA guidelines. So we also give SMA treatment for gene therapy for children who are less than 2 years, and even for kids who are above 2 years but less than 21 kgs, which EMA has approved. So we do both. When it comes to Duchenne muscular dystrophy, at this point of time, they are following the FDA approval, where it has been approved for children above 4 years of age and not for non-ambulatory ones, as you know about the change last year. So anybody who is ambulatory and less than 4 years of age, who meets the genetic criteria and all the complication or contraindications have been ruled out, we give the gene therapy for them. So they follow the FDA guidelines for that.
Is it possible to test AAV antibodies in potential candidates?
So it is mandatory. It's mandatory.
Yes, but the question is that we would like to find out whether in Dubai we can determine earlier whether the child is eligible for gene therapy before the therapy is administered.
Yes, we do that. Even before the gene therapy is given, we check whether the antibodies child is positive or negative. Because if he's positive for AVRH, we decline gene therapy. And we've done that for a few kids. Unfortunately, they came in a month before the infusion was due. We checked their AAV. The results comes back in 7 days. And because unfortunately they were positive, we said, no, we cannot go ahead with gene therapy. Some people, what they do, they check the antibody status even before they start raising funds. Even before they can go and get their funds ready, they get their child tested, and then they go ahead and raise funds. But it's thing that people choose what to do, whether they would do it before raising funds or after raising funds and before doing gene therapy. But it's mandatory.
Dobrze, ja bym chciała przejść jeszcze do kolejnego pytania. Na pewno już też częściowo padła tutaj odpowiedź, ale żeby to
moving on to the
doprecyzować,
next
jaka
question,
jest
just to be
skuteczność
sure,
terapii
what's the
Elevidys u
efficacy
chłopców
of
powyżej
Elevidys
9
in boys
roku
older
życia?
than 9 years of age?
Okay. As you know, most of the studies in Elevidys have happened between children who are 4 to 8 years, and they've been followed up for the last 2 or 3 years. So the actual study in kids who are older hasn't happened as much till now. But in personal experience, at least I can say the number of gene therapies we have given to the older kids as well. And, Tim's mother just spoke about as well. And because the viral load is larger, these kids are older, their weight is higher. So they will receive a slightly larger dose of viruses. The risk of liver dysfunction or liver enzymes going up is higher in those kids. So we have to monitor them very closely. But in terms of outcomes, the earlier you start, when the muscles are still intact, the better the outcome will be. In the next 3 or 4 years, we probably will know for older children beyond 9 years what the advantages or benefits have been. But at this point of time, I cannot say this to you because we don't have any experience or a big enough experience to give you that answer for older kids.
Dziękuję.
Thank you very
Ja
much.
może już przejdę do następnego pytania, które
I'll
też
move
ściśle
on to
łączy
the
się z
next
tym moim
question, which
poprzednim
is
pytaniem.
quite
Ile
connected
czasu
to the
upłynęło
previous
od
one?
podania
How much time has
najstarszego
passed since
leczonego
administration
pacjenta
in the
przez
oldest
pana i
treated
jaki jest
patient by
obecnie
you,
wiek
and what
tego
is the
pacjenta?
current age of that particular patient?
This is the most difficult question you've asked. My memory doesn't help me, but I think the first one we gave was 7 months back. The child was given gene therapy 7 months back, and the child had no complications initially. We have stopped monitoring him, and he's doing well. But we haven't followed him up because he's gone back to his home country. We normally bring them back after 6 months or 9 months or 12 months, depending upon when it's possible. So we will see what benefit the child had. But as far as I know, that child was, I think, 5 years of age, who took the first one in Dubai in our hospital, the gene therapy who received. So it's only been 7 months. I cannot give you right now saying that, there was a miraculous improvement in that child. Maybe next year, if you're sitting here, I can give you a better idea of what the child achieved.
Czyli musimy po prostu
So
poczekać
we need to be patient and we need to
na
wait
więcej danych.
for more
I
data to
ostatnie
arrive.
pytanie już bym zadała z naszej listy.
There is the last
Czy terapia
question
genowa jest
from the
przeznaczona
list. Is
wyłącznie
gene
dla
therapy
chłopców
intended
wchodzących?
only for
Czy mogą być
ambulatory
również
boys, or can
rozważani
non-ambulatory
pacjenci
patients
nieambulatoryjni?
also be considered?
No, currently the licensing is only for kids who are ambulatory. And as you know, I think in July 2025, there were, I think, 2 liver failures and deaths in kids who are older, who are non-ambulatory. And then they canceled, they stopped it for a month, delivering the medication. And then again in, I think, October, the regulation came in where it was opened up again. And they said You can treat any child above 4 years, but the child has to be ambulatory. What we tend to use for ambulation assessment is like a 10-meter walk. And we look at whether they can do it within 30 seconds or not. And if a child can manage that 10-meter walk in 30 seconds, they are considered as ambulatory. And we go ahead and give it to them.
Dziękuję. Na tym
Thank you very much, Doctor. That's all of our questions.
Większość pytań, które były zadawane przez rodziców,
most of the
często się
questions
powielały, próbowaliśmy je
were quite repetitive. We tried to avoid that, but still some points were repeated.
Doprecyzować do pana prezentacji.
But the point was obviously to get as precise information as possible from you, sir.
Zadaliśmy pytanie. Uważamy, że temat na chwilę obecną
So right
został
now,
wyczerpany i bardzo
we
dziękuję
believe
panie
that we
doktorze
have been
za
able to
poświęcony
exploit
czas
the topic.
i za
Doctor, thank you very
merytoryczne
much
odpowiedzi i
for
ogromną
the time
uważność
you
wobec
devoted
naszych
to
pytań.
us. Thank you for being so attentive to all
Dziękuję
of our
również pani
questions.
Renacie za
Also,
podzielenie
a
się
big thank you goes to
doświadczeniem.
Renata for
Wiemy, że to
sharing her
bardzo wiele
experience.
kosztuje.
We know that it must have cost her a lot.
I to jest bardzo ważne również dla innych rodzin. Także
this
bardzo
matters
dziękujemy.
truly to all
Jeżeli
of the
chodzi
families
o
involved.
pozostałych uczestników,
Now, in
również
terms
bardzo
of
chcę
the
podziękować
other
za,
attendees, I'd like
za
to
uczestnictwo,
thank
za
you
obecność, za
for
nadesłanie
showing
pytań.
up. Thank you for
Wiemy, że
sending
nie
your
udało się
questions in.
wszystkich kwestii
We
poruszyć.
realize the great
Rodzice z dzieci z
evidence
DMD
that
potrzebują naprawdę
parents
informacji z
with
pierwszej
children
ręki,
with
przestrzeni
DMD
do zadawania
need information
trudnych pytań.
first
I
hand.
jeszcze raz
They
bardzo
need
dziękuję
place where they can
za
ask
to, że ten
their
webinar mógł
questions.
się
So
odbyć.
thank you very
Dziękujemy
much
również
for
tłumaczkom,
the
które
option to have that webinar.
wiernie
Also, big thank you goes to
przekładały
interpreters. The interpreters
treść
also thank
wszystkich
you for
odpowiedzi, jak
bearing with
również
us.
wszystkich
We
kwestii
did our best,
zaprezentowanych na
obviously, to
prezentacji. Mam nadzieję również, że
translate as much as
że pan
possible.
doktor Arif Khan również
We
usłyszał
hope that
wszystko dobrze,
the communication
jeżeli
was
chodzi
running
o
smoothly also from your
relacje
perspective,
pani Renaty.
Doctor, and that you were
Dziękujemy,
able to
że byliście
understand what
państwo z nami
Renata
i
said.
życzę
So, ladies and
państwu
gentlemen, thank you very much for having
życzymy
spent that
spokojnego
time with
wieczoru
us. We
i mamy
wish you a
nadzieję, że
peaceful
zobaczymy się na
evening, and we
kolejnych
hope
spotkaniach.
to see you at some other webinars. Thank you.
Jeśli chodzi o sprawy organizacyjne,
Now,
to ja jeszcze tylko
some more
powiem, że
organizational information, if you
nagranie
allow me.
webinaru będzie niedługo
The
dostępne
recording
w
will be
zakładach
made available
społecznościowych na
very
stronie
soon on our
internetowej
social
zarówno w
media
języku
and
polskim,
on
jak i
our
angielskim.
website, both in
Więc jeśli
English
państwo
and
będą
in
chcieli
Polish.
obejrzeć
So
bądź
whenever
przekazać
you
komuś,
will
to jak
feel like
najbardziej
watching
będzie
it
to
again or sending it to
Dziękuję,
someone,
panie
it will
doktorze,
be
dziękujemy
possible.
bardzo.
Thank you very much, Doctor. Thank you, ladies and gentlemen.